Good evening to all. I'm Dr. Ken Piper, a moderator for you tonight, kind of pulling things together. I will be reading your questions, and feel comfortable when you do the chat. You can just put a word down, something you'd like more information, or 2 words or a sentence. We're going to focus tonight on a big problem in Oklahoma, which is skin cancers of all kinds in all locations. Medical Town Hall has been a part of the St. Francis educational program for a good many years. We've had a break, and I'm looking at the audience right now, and there's no one here, and I wish you were. And I pray that your families have been well. Challenging, troubling times, and that you're well. We're going to continue with Medical Town Halls. St. Francis very committed to continuing to reach out. The MyChart has been a boon this last year. Virtual office visits, very exciting. Virtual urgent care visits. Times are changing. And tonight we're going to be listening, engaging, questioning Dr. Johnathan Ledet, Warren Clinic Dermatology. He is a special kind of doctor approaching skin cancers in some very unique ways. He is a terrific speaker. He's been in front of our Medical Town Hall before, and I am going to let him take over right now. Thank you.
Good evening. We don't need this, as we are all virtual tonight. I want to thank everybody for taking time out of their day to learn a little bit about skin cancer, something that is near and dear to my heart. Each and every day we have people in Oklahoma, as across the United States and the world, that are diagnosed with skin cancer, and I'm hoping to shed a little light on prevention tonight. I think in regards to skin cancer, the adage, an ounce of prevention is a pound of cure, is definitely true. As someone who spends his days removing skin cancer, it is very important that we talk about prevention and what you can do to protect yourself. All right, and without further ado, I want to thank everybody for bearing with us. We had surgery run late tonight. We'll get started. So my name is Dr. Johnathan J. Thank you, Dr. Piper, for that lovely introduction. I am a fellowship-trained Mohs micrographic surgeon, as well as a fellow of the American Academy of Dermatology. I do not have any conflict of interest. We will not discuss any on-brand things. Anytime I deviate from this, I will let you know that it is my personal preference, such as sunscreen recommendations, things like that. All right, so how does the sun affect our skin? Well, the sun affects our skin in a couple of different ways. So the rays that reach Earth are primarily UVA and UVB, and you can see right here that UVA is associated with aging. So both of these sun rays are dangerous, both UVA and UVB. So they can cause premature wrinkling. They can increase your risk of developing skin cancer. Even when it's cloudy, these rays are present. So it's very important that people protect themselves from the sun. So UVB rays, as illustrated here, lead to burning. So UVA rays pass through, they can penetrate glass. So if you think about when you're driving your car down the street, the laminated glass on the front of the windshield prevents both UVA and UVB, but the side glass is called tempered glass. That does not prevent that UVA from coming through the window. So I think everyone may have seen there's a photo of a gentleman with a split screen, a delivery truck driver who spent his life delivering packages, and on the split face screen, he has many, many more wrinkles on the left side. In the United States, we have many more skin cancers on the left side of the body than we do on the right side, and that's because that is the driver's side. So UVA rays in particular can suppress our local immune system in the skin, and then it interferes with the skin's natural ability to protect itself. UVB rays, as I said previously, lead to burning. This is what happens whenever we are out on the lake. We forget to apply our sunscreen, when we forget to use that sun protection or sitting under an umbrella. So a good way to remember this is that is associated with aging, and B is associated with burning. So I get this question all the time. Patients talk about, I just wanted to go to the tanning bed because I wanted to get a base tan. We talk about, is there a safe way to tan? So the answer to that question is no. You should protect your body from UV damage. Your body makes melanin every day. Melanin is the skin in your eyes. Melanin is the pigment in your skin and in your eyes, and that gives you some photoprotection. So when your skin gets damaged by sun's rays, it tries to make more melanin, and that makes you darker. It tries to make more melanin to protect your skin from further damage. So basically, tanning is a protective response. That is a response that the body does in order to try to help us. If you notice, populations that are further or the more northern latitudes tend to be more pale. They have a more fair complexion. Populations that are near the tropics, such as the continent of Africa and whatnot, near the equator, those tend to be darker individuals because they get very intense sun exposure, and they have become dark over time as a protective mechanism. So overexposure to ultraviolet lights, both natural and artificial, changes the skin's texture. It results in breaking down of collagen, leads to premature wrinkling, causes age spots, and thus people who said they want a base tan or they want to look brown, have that quote-unquote nice brown look or bronze look for the summer, are actually doing damage to their skin. So every time you tan, you accumulate damage, and that damage increases your risk of skin cancer. So this is the UVA camera. This camera shows the damage that is beneath the skin. So we have two individuals here. We have an individual who is the individual at the top. You can see this young lady has had approximately 61 birthdays, but you can see at the bottom, this young lady is only 17 years old, and to the naked eye, it looks like she barely has any sun damage here. But you can see with the UVB, with the ultraviolet camera, that she has damage, not as much as the 61-year-old here, but you can see even at the tender age of 17, damage is already accumulating. So therefore, it is very, very important to protect your skin from the sun. So that also includes indoor tanning. Indoor tanning also, it simulates the rays from the sun. You can get burned in an indoor tanning booth if you stay for an extended time. That's how people get that tan look. They're trying to trigger that response from the skin so that they can get that tan look, which ultimately will lead to damage. So who gets skin cancer? So here we have a nice representation, a nice cross-section of America. We have dark brown persons, medium, light brown persons. We have white persons with, olive-colored skin and more fair skin. So 1 in 5 Americans will get a skin cancer in their lifetime. I think that it is very important for people to understand that just because you are dark complected, you still will sunburn. So if all these people go on a fishing trip, basically they all will burn. It's just that it becomes a function of the amount of time that they spend outside. So this young man, being the darkest of the individuals on this slide, he will take the longest to burn. Next would be the young man here, so on and so forth. So the darker you are, the longer it will take for you to burn, but you still will burn. All right, basal cell. So on our next slide, what are the types of skin cancer? Well, knowing the types of skin cancer are very important. We also have precursor lesions to skin cancers, but as we're focused on skin cancer tonight, we're only going to talk about the actual cancers. So we have basal cell carcinoma, squamous cell carcinoma, melanoma, and in the United States, more than 3.5 million people are diagnosed with skin cancer every single year. And that happens in about approximately 2 million people. So it's important with these skin cancers on the rise is actually the most common the most rapidly rising skin cancer among those aged 25 to 29. Early detection is important in all three types. So we'll take a look at which types, what leads to formation of each type. So basal cell carcinoma. Basal cell carcinoma is the most common skin cancer worldwide. Basal cell carcinoma typically appears on sun-exposed surfaces, such as the face, the ears, the chest, the back, and the legs. So these tumors can have several different forms. So if you look here, you get an ulcerated plaque. There's an ulcer in the middle. We have a rolled border. You may have heard this is called like the rodent ulcer. People can have a pearly papule, such as the picture on the upper right here. Sometimes these lesions, you may have a sore. It may present as a sore that will be painful. It also may bleed. After it bleeds, it may heal and then bleed again, bleeds without contact, or bleeds with light contact. You get out of the shower. I get stories every day. Someone says that they were in the shower, they were washing their face, and they had a spot on their cheek that started bleeding. They come in to see us. We get a biopsy of it. That biopsy eventually shows that it is indeed a skin cancer. So multiple studies have shown that if you have at least one basal cell carcinoma, you are 40% more likely to get another basal cell carcinoma within 5 years. This is why screening is important. We screen people every day in our office. So what are the risk factors for basal cell carcinoma? So the risk factors include chronic sun exposure. Excuse me one second here. So chronic sun exposure. The more, as discussed earlier, the more sun exposure you have, the higher your risk of developing not only basal cell, but also squamous cell skin cancer as well. If you or someone who grew up in the 60s and 70s, back when they used to do radiation therapy for acne, that is an increased risk for skin cancer. So being immunosuppressed, we have lots and lots of transplant patients. The miracle of modern medicine is that you can take a kidney. If you're someone who was on dialysis, you can take a kidney from one human being, put it in another human being, but in order to keep that kidney, we have to use immunosuppressive drugs. And since we are using those drugs that suppress our immune system, things slip through more readily. Transplant patients have a much, much higher risk of both basal and squamous cell carcinoma. They get skin cancer at much, much higher rates. Increasing age is also a risk factor for skin cancer. That is because we are a population that previously was very agricultural. We have in Oklahoma, we have lots of people who still farm. We have wheat farms, hay farms, etc. So all that time outside leads to accumulated sun damage. If you think about tractors from back in the 60s and 70s, they didn't have cabs on them. So we went from cabs without tractors. Now they're pretty nice. They have cabs on them. They have satellite radio. They drive themselves, all these things. Exposure to arsenic, that's also been found to have a higher incidence of skin cancer. So people who grew up on farms that had well water and there was arsenic present in the well water. And lastly, there's some inherited syndromes that are rare that also can lead to multiple skin cancers. All right, so squamous cell carcinoma. Squamous cell carcinoma is the second most common skin cancer. We see about 700,000 cases of squamous cell carcinoma in the United States every single year. So how do these present? Well, like a basal cell carcinoma, they are most prevalent in sun-exposed surfaces. They can present as scaly plaques. This has a precursor lesion known as an actinic keratosis. People come to our office every day, and there's a variety of different ways of treating that. We use liquid nitrogen at times. We may use 5-fluorouracil or other topical agents to help treat the precursor lesions for squamous cell carcinoma. Squamous cell carcinoma, if left untreated, like a basal cell carcinoma, will destroy the local tissue. I cannot stress enough how important it is to treat skin cancer as soon as you recognize that it is present. So both basal cell and squamous cell carcinoma are both readily treated when detected. They're both readily treated early. We have lots of techniques. We have excisions. We can perform excisions with standard of care margins in order to do that. Myself, I perform Mohs micrographic surgery when it's on the head and neck, or if it's in an area that requires skin-saving technique, such as the hands or the feet. So Mohs micrographic surgery, what are the benefits of it? I get this, I get this question all the time. So one of the benefits is that it allows for tissue conservation. So the way we do Mohs micrographic surgery is you come to our office, you're awake during the entire procedure. We anesthetize it using a local anesthesia. During that local anesthesia, we allow that approximately 20 to 25 minutes to set up and diffuse through the skin, so that allows us to use a lot less local anesthetic. So then we come back in, we remove the tissue. After we excise the tissue, it is then transported to our lab, which is down the hall from our surgical rooms. In the lab, the specimens are cut, inked, stained, processed, and analyzed. We analyze that under a microscope. So, for example, if you were a patient who came in and you had a basal cell carcinoma on the cheek, then we would proceed with surgery. If you were found to have basal cell carcinoma in the left upper quadrant, then we would come back and excise only the left upper quadrant, and the microscope guides where we need to go next. So we examine, unlike traditional pathology, we examine 100% of the tumor margin, which thus leads to the lowest recurrence rate of all the available therapies and the highest cure rate. So melanoma. Melanoma is very, 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 very important. So it is the most serious form of skin cancer that we have. So melanoma is characterized by the uncontrolled growth of the melanocytes, the pigment-producing cells. Sometimes they can appear suddenly without warning. Sometimes they can arise in a mole that was previously there. They frequently appear also on sun-exposed areas, but like any other cancer, may appear on a non-sun-exposed area. It is estimated that we have approximately 140,000 cases of melanoma each year in the United States. So the most common place for a melanoma in a man is on the upper back. In a lady, it's on the lower legs. And this is something that we have borne out in our practice. So you can see here, so melanoma, it looks weird. So when should you see your dermatologist? When should you see someone about catching a skin cancer? So the answer is you should see that person as soon as you notice something is wrong. So if you look at these melanomas here, so here we have what looks to be, if you look at it from a distance, you would say, hey, this is a normal mole, with the exception of we have this very odd area in the center. So also, if you look down here, this is an area that has multiple areas of pigment. It's an irregular shape. In a minute, we will talk about what are called the ABCDEs of melanoma. So you can also have nodular melanoma. So this is an example of nodular melanoma right here. It comes up, it's jet black, it's a darkly pigmented spot, may bleed spontaneously, may ulcerate. And lastly, this is another area. You can see that this is multiple colors, has areas of hypopigmentation, dark jet black areas, has an irregular shape. So these are all be examples of melanoma that are important to get checked out. So one person dies every hour. So in 60 minutes, so in the time that we have been here tonight, giving a talk and answering questions, one person will have expired from melanoma. This is the most common form of skin cancer among young adults 25 to 29. And it's the second most common cancer among adolescents and young adults 15 to 29. So here we have some other examples of melanoma. And time, this clock just illustrates that time is of the essence. All of us procrastinate at times, and I think it is very, very important that if you notice something that is irregular, that you get examined. So who gets melanoma? So again, we have a cross-section of the United States. So while it is true, melanoma is most common in fair-skinned individuals, light-colored eyes, people who have lots and lots of sun exposure. If you have over 50 moles, if you're a person who is, quote, very moly, patients say that all the time. If you're a very moly patient, you have a higher incidence of melanoma. If you have other relatives who have had other blood-related relatives that have had melanoma, it's important to consider that history. So what happens a lot in families is that, lifestyles are inherited. If your father's a farmer, or if you're a family who loves to boat or fish and whatnot, those people hang out together and they go out and they're enjoying the sun, enjoying the great outdoors together. And I can't stress enough how important it is. So Caucasians are at a higher risk of melanoma. So in In African Americans, such as myself, more commonly we see acrolentiginous melanomas. So those are melanomas that start on the hands and feet. But in a Caucasian person, they are the most common just because they're at increased risk of sunburn and damage, etc. So if you've had multiple skin cancers, if you've had multiple basal cell carcinomas or multiple squamous cell carcinomas, you're at a higher risk of melanoma. And that is just because you've had more sun exposure than someone who has not had those ailments. So the ABCDEs, we go over this with nearly every melanoma patient. It's very important that people recognize these. We try to affirm these every year to those people who have melanoma, and as well as people who have lots of moles. So it's pretty simple. So we'll go through it together. So A for asymmetry. Well, if you cut it in half, does one half look like the other half? Does the right and the left half, are they mirror images of each other? You can see here clearly this is not. We cut this down the middle. The right half is significantly darker than the left half. The left half has multiple different pigment foci present. So that would be 1 point against this particular lesion. Borders. So let's look at the borders. So the borders on this lesion are scalloped, they're notched, they're regular. The borders are not readily defined. So that is something that is irregular. The body tries to make things that are as symmetrical as possible. So color. So sometimes we can have color variation. One color is normal, two colors can be normal. So as we increase in both the number and the types of different colorings, that should set off red flags. So in this particular lesion, we have some areas of tan, we have some dark black areas, we have, melanoma can also have areas that are blue, or it can look red, they can be very inflamed. So we need to keep color in mind. So there was a great study that showed that if you had something present and it had more than 3 colors, so 3 or more colors, it had a 2/3 chance, so greater than 66% of being a melanoma. Diameter. So diameter, this one, most melanomas are greater than 6 millimeter. 6 millimeters, approximately the size of a pencil eraser. That is, as you can see, this particular lesion is less than that. But the key thing here is if you notice something and it wasn't there before, that's also important. Evolution. So moles are skin lesions that change. They change in shape, they change in size, they change in color. If you are concerned about it, you should get it looked at by someone who does this all the time. So E is for evolving or changing. So if things are changing and you think it just doesn't look right, we should get it examined. So family, we have, in the middle of a COVID-19 pandemic, I think all of us have spent lots and lots of time with our family. Hopefully everybody is still in good spirits. I want to encourage everyone to get vaccinated. So you should screen the people that you love, especially if they're at risk. If you have a loved one who is exposed, they're not only people who are in the sun regularly, but anyone. People don't look at their back. When we see people in our office, if they come in, even if they come in for just a word on the hand, we ask them, hey, can I look at your back? Because that may be the only time that person, especially because we see a younger population, that may be the only time that person has somebody to look at their back. So your loved ones, your family, your friends, we need to screen these people. So the best time to screen those persons, if you're going out, you're going to the beach together, you're, changing clothes, etc., your loved ones that you see every day, that is a perfect time to look at their back, look at the backs of their legs, places that people may not look. And you can talk about screening. I think communication is key, and just talk about, hey, let me look behind your ears, let me check. So we see people in our office, depending on your history of skin cancer, anywhere between 3 and some people get seen once a year, some people get seen twice a year, some people get seen every 3 months, just depending on their history and type of skin cancer. Dr. Piper.
As soon as you said, get it checked, get it examined, the questions started lighting up.
Not a problem.
And it's a very good question. If you're screening someone, your family, you're looking at yourself, it's changing, It's got arms and legs and multiple colors. It's getting bigger. Where do you start? Because for many dermatology offices, the waiting time is long.
That's a great question. And the person you can start with is the person you see all the time. It's your family practice provider. It's your primary care provider. It's if you're going to see even if you see your cardiologist. One of our fantastic cardiologists here at St. Francis sent me a skin cancer just the other day, Dr. Basal. He sent me a message and he said, "Hey man, I'm sending you this person. I think she has a basal cell." So he caught the basal cell even though that's not his primary specialty. So if you're in an office, if you're seeing one of our fabulous APPs, advanced practice providers, or one of our physicians here at St. Francis, we should ask that person if you're concerned about something. And they are, they have had, all of us in the medical profession have had some training. That way you can get a more immediate answer. Next question.
And when you contact that provider, will they usually set up a biopsy to get an answer? Because a lot of skin lesions are going to be age-related, non-malignant.
That's correct. So what do we do in that case? Well, you go to that provider. I think if they are set up to do biopsies, we have lots of family practice providers and internal medicine providers who may do biopsies in their office. If they are set up to do the biopsy, I believe that they will do it for you. If it's a skin cancer, they will send you to us, usually to have it treated, or as appropriate. Some melanomas are more aggressive, and they require a lymph node biopsy. So we work in conjunction with our fantastic plastic surgery colleagues. We work with general surgery. We have some fabulous surgical oncologists, etc. So, all right, continuing on. So how do you spot a skin cancer? So this is an example of the properly screened. So the American Academy of Dermatology encourages everyone to check their skin on a regular basis. So what does regular mean? As often as you remember. So basically, you can get in front of a mirror. You can check your own torso. You can use a mirror to check your back, check under your arms, especially if you are a person who has a lot of nevi, a quote moly person. I cannot stress enough the importance of screening. So you can check your scalp, go through your hair. When you come to our office and we do a full body skin exam, we pride ourselves on going from head to toe. We go through your hair, we look behind your ears, between your toes, between your fingers, et cetera, et cetera. And that is very, very important to check all of those areas. So preventing skin cancer. So we need a broad spectrum sunscreen. So what does broad spectrum mean? That is a sunscreen that will protect us against both UVA and UVB rays. That is a sunscreen that may have, sunscreens can be labeled as, quote, physical blockers. That would be titanium and zinc, or organic. That was a titanium and zinc. Other ones there are some chemical sunscreens, such as some of the benzones and whatnot. They go on clear, but they still do a pretty good job of protecting us from the sun. So it's very important that it be SPF 30 or higher. This is a hot button issue. We talk about it every day in my office. Well, what sunscreen should I get? So everybody should know that SPF, these numbers are tested in a lab. Right, so it says 30 blocks 96% of rays, and 90 blocks 99% of rays, and 100 blocks 100% of all the rays. But none of us put it on as it is actually recommended. So, and also, hardly any of us reapply. If we're being honest with ourselves, we don't reapply in 80 minutes. We don't reapply in 2 hours. What commonly happens is if you're going to spend the entire day at the beach, what happens is you put your sunscreen on. Most people are putting their sunscreen on as they're sitting out next to the ocean, and they're using the spray, and it's spraying all over the place, and then they end up with streak patterns all over the place. So the best time to put on sunscreen is when you're changing into your bathing suit. That way you have the most skin exposed. It's okay to have a little you want to put that sunscreen so that all your skin is covered, especially that skin that's going, right underneath that bathing suit, because it may ride up, et cetera, et cetera. So when you're changing into your bathing suit is the best time to do it. So I always recommend people get a high quality and high SPF sunscreen, because most of us are not going to reapply. Most of us don't put it on as thick as need be to actually get that SPF 30. There was a great study done, 860 people, that showed that most people, the average person, puts it on somewhere between a quarter and half as thick as it needs to be, because especially in terms of zinc, which is a fabulous sunscreen, zinc or titanium, they go on somewhat white, and that bothers people. They want it to look like they're not wearing anything at all. So then that obviously, if you're putting on less of it, is going to have less of an effect. Dr. Piper, question?
Two questions
Yes.
have come up. One question is, it's cloudy outside, I'm at the beach, and I'm not going to have trouble. So what's the value of overcast skies in protecting you, or does that not make a difference?
It's important to recognize that those ultraviolet light rays are still present. They're still present even on cloudy days. You can get a sunburn on a cloudy day. So we still recommend using high quality sunscreen, using sun protective clothing. So if you look on the clothing, it's UPF, ultraviolet protection factor. So that is very, it's important. It's important to protect yourself on any day that you're going outside. I tell patients all the time, I told someone today, when I cut the grass outside, I wear one of those fishing shirts. I wear a wide brim hat. I wear eye protection. I wear those things so that I can protect myself from the sun, even though my risk of getting a skin cancer is lower because I'm African American. So basically, how much sunscreen should you use? So there's the 1 ounce rule here. So 1 ounce of sunscreen is what you need to cover the exposed areas of the body. Some other things we can do. We talk about this every day. Wearing a wide brim hat, using an umbrella if you're at the beach to protect yourself, and taking that sunscreen with you. So you can reapply as necessary. It is important that we set a timer, we redo it. If you notice someone's getting in your group that is becoming a little red, et cetera, it's important to tell that person and offer them sunscreen, apply it, help them put it on their back, et cetera. So I get a question all the time. I want to go tanning so that way I could get a base tan, or I can get my vitamin D level up. So we know that there are lots of good ways. The sun does help in the synthesis of vitamin D so that we can have strong teeth and bones. But we know that we can get that from milk. We have vitamins that are fortified, that have vitamin D in them, multivitamins, etc. There's other ways that we can do that. So basically, this young man right here, this is a picture of a person that's appropriate hat for not only going to the beach, but also it is appropriate for just everyday use, cutting grass, going to the ball game, et cetera, because a lot of times we go to a driller's game, we put a hat on, we put a ball cap on, and then we let our ears fry. So you should seek shade between 10 and 2 p.m. That is when the sun's rays are most intense. Wearing sunglasses is also important. This young man has sunglasses on. That's important because you can get, as I talked about earlier, you can get melanomas of the eye. And the people who diagnose that are fabulous ophthalmologists and optometrists. So you should seek shades. You need to protect children by using those same things, sun protective clothing and sunscreen. So lots of tanning boots are unregulated. So some persons can utilize those tanning beds without supervision. There's no time limit, et cetera, et cetera. So we always say in our office, on your birthday, get your birthday suit examined. So you come in, we get you down to your undergarments, and we try to screen you head to toe. All right, so we'd like to open it up for questions. We use about half our time, and we can field any questions that our group may have. Thank you all for paying attention, and thank you all very much.
Couple of questions.
Yes.
The total body skin exam.
Yes.
One question is, who is doing that now? Because most physicians are not, unless there's issues, concerns, family background, or specific things. Should someone see a dermatologist for a total body skin exam?
So I think, it is I think in dermatology, we do them every day. Both myself, my partner, Dr. John Ashley, and our fabulous APPs, we do full body skin exams every day. I understand that if you're seeing your primary care provider, they may say, hey, you have a bunch of moles. I think you need to go see someone who does that every day. And that is understandable. So I think if you make an appointment at your friendly dermatologist, they are happy to see you for a total body skin exam. So who should get them? You know, if you have lots and sun damage, if you have a history of tanning, if you have basically a history of tanning, if you get a lot of sun exposure, a lot of moles, as we discussed, all those things would be great reasons to get checked out and make sure that you get a head-to-toe exam, at least a baseline, because it's the areas you don't check. When's the last time anybody's looked at their back or looked through their own hair to look for skin cancer? Hairdressers are very important. They help dye our hair. They help cut our hair. They go through our hair. They may tell you, hey, you have a spot here that wasn't here 3 months ago when I cut your hair. So we get referrals from hairdressers all the time. Okay.
Questions on sunscreen. Would you recommend a brand?
Okay, so recommending a brand. So, this is always a hot button thing. I don't have any stock I like Neutrogena just because I think it's a high quality sunscreen. It does meet, has a good efficacy and price point. There are multiple studies that show if you buy the non-brand sunscreens, sometimes the represented SPF just doesn't hold the mustard. They can't pass the test. So we have lots of great brands. Blue Lizard is a fabulous sunscreen. It's Australian based. It's all zinc, so it goes on white. So some people don't like it, but Blue Lizard. I have a daughter that has sensitive skin. She has eczema, so we cannot use any chemical sunscreens. We can't use any inorganic sunscreens on her. We have to use quote the organic sunscreens, which are basically just titanium and zinc.
Mm-hmm. And this is a question I would have asked, sure. But we had two of them,
yes. Which
is, I've got sunscreen sitting in a drawer that we bought 5 years ago. Mm-hmm. Does that stuff wear out? Does expiration date mean anything?
So expiration date is important in terms of, chemicals can break down over time, especially if it's sunscreen that we have let sit in our car. And basically, it's sat in a car, it's gotten up to 140 degrees, it's basically boiled. When you put the sunscreen out, it's in two separate components. That sunscreen is probably not effective.
The question about melanoma, mm-hmm. a couple different approaches. You are part of a team in melanoma.
Correct.
So if melanoma is diagnosed somewhere on a biopsy.
Correct.
General surgeon may look at it.
Mm-hmm.
You're part of a team that will look at, okay, where is this melanoma? How deep is it?
Right.
Are we going to approach it with your kind of surgery where you find it and track it, get every little arm, leg, and root? Or maybe a general surgeon will do a bigger incision, get a lymph node involved.
Correct.
Maybe an oncologist will be part of it because we suspect spread internally. So I just want to emphasize that you are a team approach in the St. Francis system.
That's correct. I think that one of the beauties about being at St. Francis is we do have a team approach, not only to melanoma and other skin cancers, but plenty of other diseases as well. But as far as melanoma goes, yes, it is very important. So the depth is important. I have patients who were sent to me from oncology, our fabulous oncology colleagues that, they may have a person who is on immunotherapy or they're on, they need skin cancer surveillance, so they'll send them to me. So I am part of the team. Depending on the depth your melanoma or the stage of your melanoma, we can kind of get you to where you need to be. We work hand in hand during surveillance with oncology, we work with plastic surgeons, we work with general surgeons, all surgical oncologists, etc. So all the members of the team are important because everybody has slightly different expertise, but it takes all those different expertise so we can have a successful outcome.
Mm-hmm. And when you can take it on, I love this term, micrographic. Right. Micro meaning just light little micro shavings. Right. And then graphic means take it, look at it. But that might mean patients have to sort of stay with you for several hours or maybe part of the day.
So we tell people when we're using Mohs micrographic surgery, We mainly use that currently at our institution for non-melanoma skin cancer. So if we're taking out a basal cell, squamous cell, etc., we make sure to educate the patient on a consult visit. We do consult visits in our office because I think that surgery is immensely personal, and I think that it's important to meet your surgeon, talk to them beforehand. Basically, and then we explain the whole process. So that process from going to the lab, it getting cut, stained, processed, inked, and analyzed, that may take up to 60 minutes. So basically we tell people, and we don't know how many layers you're going to go. So we tell people, block off your whole day for us. Eat a hearty breakfast because you're going to be with us, right? Take all your medications. One of the beautiful things is we rarely stop anticoagulants. So that way, if you're a person who has, if you're on Coumadin or on Xarelto or on any of these either antiplatelet drugs or anticoagulant drugs, you can feel comfortable in knowing that we can take care of it while you're still on those therapies.
So local anesthesia.
So local anesthesia.
Followed carefully.
Office,
may
right.
have to spend hours or part of a day.
Yeah, so we tell you to bring a lunch. I think I tell patients all the time, people are happier when they eat. So while we have snacks and coffee and whatnot in our office, we don't want to tell you, hey, you're going to be done by 12 and you're still there at 2:30, but everybody's happy if you say, plan the day, it's 10:30, you get to go home. Everybody's happier that way.
And when you are at that point and you've taken every little area, tracked it down,
right.
The cancer's gone. Chance of recurrence, low.
With most
better than
micrographic
general
2%.
Surgery. Cure rate, high. And there's going to be some scarring. You're
Yes.
going to be shaving in. How do you handle scarring? Are there techniques, ways, approaches you take after your Mohs surgery?
Well, so each patient is individual. So with everything, just like with your actual diagnosis of skin cancer, the type of skin cancer, whether you have a basal cell carcinoma that's just superficial, or is it infiltrative? Are we going to have to utilize the services of ENT? We have fabulous ear, nose, and throat surgeons here. Sometimes we go down, if it's a really aggressive squamous cell carcinomas, may get into the parotid, et cetera, and we rely on those colleagues to help us with that, to make sure that the parotids, parathyroidectomies, done, et cetera, so that they remove the parotidectomy, so that they remove the parotid if that is indicated, et cetera. So it's just very important that we take each case by case business. So we try to put in absorbable sutures when we can. We try to have patients after that initial 3-week period. We tell them, there's been multiple studies done, and the only thing that's actually been shown to work better than just plain Jane Vaseline. So some people use A&D ointment, bio oil, Mederma, etc. The only thing that's actually been clinically proven to work better is silicone gel sheets. You can use those at approximately 3 weeks. After 3 weeks after surgery to help minimize scar. They help with the maturation process of scars.
So again, a team approach, sometimes a plastic surgeon
That's
afterwards, ear, nose, and throat, different approaches,
Right.
individualized. Sounds
It's
like
individualized. So for example, today, obviously we can't say any names, but we had a patient today who was referred to us from Triad Eye Care. We removed a skin cancer on, it was basically the left cheek and left lower eyelid. So we removed probably 2/3 of their lower eyelid, and they're going to go back to Triad tomorrow. So that's an example. Even people who are not in our system, we are able to provide those services for them, and then they got repaired by oculoplastics in order to make sure they have maximal function of their lids. We got some hot button topics.
This is what is the secret to get an appointment to a dermatologist? I quote.
Okay, what is the secret? Well, I think, urgency is important. I think getting if it's something that your primary care has already diagnosed, I think it's important to get that exam. You make the appointment. We ask that you be patient. We are trying to recruit. We have a fabulous recruiting team here at St. Francis for physicians. We are trying to recruit more dermatologists. Only about 400 graduate every year. Some of those go in the Mohs micrographic surgery. Some of those go in the dermatopathology. So our net actual dermatologist is not high in the United States every year. And then if you couple that with 400 graduate but 300 retire, you know. So make the appointment. If it's an urgent need, if it's bleeding and whatnot, you say all those, you let the person know, and we try our very best to work on it. We have e-consults now. I'd like to put a plug in for that. We have some of our, you can go to your primary care. Some of them will take a picture of the lesion, and that way it's a way to get you a more immediate answer. Yes, this is a melanoma. Please, yes, this is a skin cancer. Please schedule with me sooner, et cetera, and then we'll get those people in. If there's a particular thing, if you just need a baseline, then if you just need a baseline, then basically, you get on the schedule, you'll get that at our office. Our wait can be anywhere between 6 and 10 weeks, just depending on the time, but we work in urgent things every single day. It's also important to realize that not only our office, but every office has cancellations. So if you are willing to come in on short notice, we have a cancellation list. We talk to people about that. We say, hey, would you like to be put on our cancellation list? And we'll call you when people cancel, we try to fill those spots so that way we can get people taken care of.
Just help me with, we have virtual office visits, virtual urgent care.
Yes.
And you have e-consult.
Yes. So that is a consult where, let's just say one of our family practice providers, so I'll use Dr. Brent Dennis, for example. So, I think I get 2 or 3 e-consults from him every week, which is fabulous. So, he sees a patient, he may be managing their diabetes or something like that. If you see a St. Francis physician, especially here at the Yale campus, we can do e-consults. Basically, he'll see someone, they'll say, hey, I have this skin thing. If he knows what it is, he will let them know. If he's unsure of what it is, he will say, hey, let me get a photo, and I will get it over to dermatology, and we'll give you an answer within a couple of business days.
Very nice. Which leads to looking at the future that is kind of almost here, which is there are applications you can now download onto our little computers that we carry around.
Yes, that's right.
What's your thought on that?
Well, I think I think that video visits are great. Video visits it helps patients have an efficient visit. Especially if it's a chronic problem. We do a lot of video visits in our office every week. I like it especially for follow-up visits. Somebody has eczema, we're going to treat that eczema, and most of the patients are going to get better. So rather than them coming in the office, we can do, as many of you are joining us live from your home here today, we can do that visit in the comfort of their own home.
Well, this has been a very enjoyable hour with you, Dr. Ledet. We have, it looks like, kind of finished the question phase of our evening. Do you have any final thoughts?
Yes. So I'd just like to remind everybody that it's important to protect yourself from the sun. It is springtime. I hope that everybody goes out and enjoys the great outdoors. We want you to do so safely. We want you to do it with a wide brim hat, with sunshades, sunscreen as appropriate. And we really appreciate everybody. Screen your loved ones, as we talked about here tonight. And if you're concerned about something, ask a question. Ask your primary care provider. Ask a dermatologist. Make a dermatology appointment. Okay. All right. Thank you all.